Good evening and welcome to HKL RT series Radiation in Hematological Malignancy Part 4. I'm Dr. Anindya Kumar Balakrishnan and I'll be presenting on solitary plasmacytomas and multiple myelomas. So this is the paper by Ilrock on these two malignancies. So solitary plasmacytoma is accumulation of monoclonal B cells in the bone or soft tissue with no skeletal involvement. So usually for solitary plasmacytoma, there is no clonal plasma cell seen in bone marrow or seen less than 10% and absence of end organ damage. So let's look at some diagnostic criteria. So solitary blown plasmacytoma or solitary extramedullary plasmacytoma, you need to have a biopsy-proven solitary destructive lesion with clonal plasma cells seen, absence of clonal plasma cells in the marrow, normal skeletal survey, and if PET-CT is available, it should only show that solitary lesion with absence of an organ damage such as hypercalcemia, renal insufficiency, anemia, and other bony lesions. For solitary plasmacytoma with minimal marrow involvement, is all the criteria as above, but the clonal uh, plasma B cells in the marrow should be less than 10%. So SBP versus SEP. So for the solitary bone plasmacytoma, it has higher risk of progression into multiple myeloma, which is 60 to 80% in 10 years and almost 100% in 15 years. As compared to solitary extramedullary plasmacytoma, the risk of progression to multiple myeloma is only about 30% in 10 years, but it also has a higher risk of local recurrence, hence the higher dose of radiation therapy. Surgery is one of the treatment modality in solitary plasmacytoma. Main function being stabilization of involved area, for example, spine decompression surgery or vertebroplasty. Pathological fractures to stabilize pathological fracture areas and surgical instability of weight-bearing long bonds that are involved. So radiotherapy in solitary plasmacytoma, it's a very residual sensitive tumor with excellent long-term control up to about 90%. So 25% of head and neck tumors usually present with involvement of nodes. So this should be proven by MRI or PET-CT. Involved nodal tissue should be included into your CTV, and elective nodal irradiation should be considered as well if there's already an involved node. If there is no nodal involvement in either MRI or PET, there's no benefit in prophylactic neck node irradiation. So dose recommendation based on ILROC is usually 2 degrees per fraction. For solitary bone plasmacytomas that are less than 5 cm, a total of 35 to 44 degrees is adequate. For lesions of bone plasmacytoma 5 cm or more, 40 to 50 degrees is recommended. For solitary extramedullary plasmacytoma, a dose of 40 to 50 degrees is recommended. In cases of small areas, well-defined areas post-excision with positive margin, a 40-degree dose is acceptable to consolidate the area. Target delineation for solitary plasmacytoma, the gross tumor volume should include the tumor that is seen in the MRI and the PET-CT. The CTV should be an expansion about 0.5 to 1 centimeter from the GTV. If it's a long bone involvement, 0.5 to 1 centimeter axially and 2 to 3 centimeter proximal, and distally should be grown from the CTV with the presence of MRI and PET. In absence of PET and MRI, we should consider to include the entire long bone in the CTV. And the PTV should be a 0.5 centimeter expansion from the CTV. This is an example of a plasmacytoma of the maxilla. As you can see, the tumor is involving the entire maxillary bone, involving the nasal septum. There's also enhancement of the medial right maxillary wall here. And as you can see, this is the GTV that is drawn in red, and the CTV that is drawn in green is expanded about 0.5 centimeter all around, with another 0.5 centimeter for the PTV. This is a very small expansion uh, because there is already presence of MRI and PET-CT to clarify where is the initial extent of the tumor. So you can use those small expansion if these images are readily available. And this is for the same patient. This is a PET-CT 1 month post radiotherapy. You can see there is mild uptake, not as strong as before, around the area of the maxilla. There's still some soft tissue occupying in the left maxilla, but there is no longer a high SUV uptake. This is a CT that is done 20 months after the radiotherapy, which shows resolution and shrinkage of the soft tissue in the left maxilla. This is an example of a nasopharyngeal solitary extramedullary plasmacytoma. So with the presence of the PET, we can delineate properly the extent of the GTV. The CTV should include the entire nasopharynx, and we should also rely on the PET to see if there is any involvement of neck nodes. So in this case, we do not see any contouring that extends beyond the primary tumor. So I believe there is no neck node involvement in this case. So for multiple myeloma, it's a systemic disease. So the role of radiotherapy is mostly to control pain, to control the disease bulk, and sometimes cold compression, so symptomatic relief. So multiple studies has been comparing efficacy of various dose fractionations in multiple myeloma. The ILROC recommendation for multiple myeloma, if it's a bone lesion, 8 gray in 1 fraction, 20 in 5, and 30 in 10 should be considered. This is also depending on patient's fitness, whether the prognosis is going to be good, or patient is going to live longer, or uh, the area that we are irradiating is going to give a significant response and improve the general condition. 20 degree in 10 fraction or 30 degree in 15 fraction should be considered in areas of free irradiation for multiple myeloma, and cord compression or bulky mass, we should try to irradiate them to a higher dose, because we know that these tumors are radiosensitive and they would shrink rather quickly. So that's all from me for plasmacytoma and multiple myeloma. Thank you.